Good. You good to go?
Yeah, let's do it.
Perfect. So I'm Ori. I'm an internal medicine clinician from the north of England, and I'm going to talk about contrast media associated acute kidney injury. As I said before, my computer sometimes makes my voice a little bit robotic or sometimes go too fast, so just chip in if that's happening. So what we're going to go through today is the properties of iodinated contrast media, the pathophysiology of contrast media associated acute kidney injury, the definition of CMA, CMA in human medicine, CMA in veterinary medicine, and finally finish off with the critique of the paper we sent around. So contrast media associated acute kidney injury is typically seen with iodine-based contrast media, but it can also be seen with non-iodinated contrast media, such as ASVNU, although that seems to be quite rare in the human literature. Contrast media can be ionic or non-ionic, and those ionic contrast media are negatively charged, and they tend to have a much greater tendency to interact with biological structures, and also seem to have a much greater intrinsic osmolality, which, as we'll come to, tends to have a higher incidence or higher association with acute kidney injury. The non-ionic contrast media tend to have, again, lower osmolality and thus tend to be associated with fewer adverse events. So if we look at this table of contrast media, I'm going from the top, which is the high osmolar contrast agents. These are the older generations, ones which most of these studies are based on. And going all the way down to kind of the isoosmolar ones, which are the newer generations, the ones we're using both in human and veterinary medicine commonly. And as you can see at the top of the table, some of these older ones, their osmolality is approaching 6 to 8 times that of plasma. And they also tend to be more commonly ionic, so tend to have an increased reaction with biological structures. And then again, conversely, as we go further down that table, the osmolality tends to decrease, same with whether they're ionic or non-ionic. Interestingly, the viscosity doesn't seem to correlate with the osmolality. There is some suggestion that the viscosity of the contrast media also has an influence of the incidence of contrast media associated acute kidney injury, but as we see here, it doesn't tend to correlate with the osmolality. So the pathophysiology behind contrast media associated acute kidney injury tends to involve two main mechanisms which are intrinsically linked. Well, alterations in renal blood flow and also direct tubular toxicity. Look at the schematic on the right from the New England Journal of Medicine, and we'll go into some of these bits in a little bit more detail over the next couple of slides. On the right side of the schematic, we've got those changes in the renal blood flow, so vasoconstriction, capillary sludging, thrombosis, etc. And on the left side, we have those tubulo-toxic changes, loss of polarity, direct apoptosis, etc. Now, one of the interesting things to note about this is there's crossover between the two. So that top circle, we've got kind of the patient factors. What are they undergoing? Is it coronary angiography, and they've got underlying cardiac disease or tube perfusion, etc. And at the bottom, bottom crossover is quite an important one, and it's this tubular glomerular feedback. In that, as these proximal tubular cells become damaged as a result of contrast media, you get that loss of polarity, reduced absorption of sodium, and consequently chloride, increased delivery to that distal convoluted tubule, activation of tubular glomerular feedback, and reduction in renal blood flow as well. And then kind of a converse picture is that renal blood flow changes leading to hypoxic change of that proximal convoluted tubule. So with regards to the alterations in renal blood flow, the main mechanism is vasoconstrictor of the intrarenal vasculature, and that's the main hemodynamic change we see with contrast media. Those mechanisms are a mixture of an influx of calcium, increased endothelin release, increased sensitivity to vasoconstrictive mediators such as angiotensin II. And we also get inhibition of vasodilatory mechanisms, prostacyclin, etc. Look at this table on the right, well, it's this diagram on the right-hand side. It's one of the experimental studies back in 1970. And in this study, they used one of the older generations of these high osmolality contrast media, and it was direct intra-arterial administration of the contrast media and looking at renal blood flow. What we can see in that first kind of minute is there's quite a sudden increase in renal blood flow. I guess that's most likely due to the fact that you're giving 3 mL of fluid into the renal artery. But very shortly afterwards, there is a, I guess, 30% decrease in renal blood flow, but it does seem to be quite short-lived, about 15 minutes or so. So yes, we do get an alteration in the renal blood flow as a result of this contrast media, but it seems to be short-lived. But there are some human studies suggesting that that effect may be a bit longer, maybe 60 minutes as well. Where this predominantly acts is in the corticomedullary junction, so there's some suggestion that these changes, some of the other ones, have more of an effect on that thick ascending loop, the loop of Henle, given the location as well. But you also get a knock-on effect, having hypoxia and getting hypoxic damage to areas of the tubule as well. And we get, as I said, secondary tubular damage as a result of reactive oxygen species. Going back to that last schematic again, another area of that can affect the renal blood flow is this increase in tubulo-glomerular feedback as a result of a primary loss of polarity in the proximal convoluted tubule cell, increased delivery of sodium chloride to the distal tubule, and reduction in the afferent arterial blood flow. If we look at the direct tubulo-toxic effects of contrast media, the predominant effect, as with pretty much every aflatoxin we seem to see, is on those proximal convoluted tubules, presumably as a result of a greater oxygen demand. Mechanisms include osmotic nephrosis, localization, as we can see on some of these H&E slides on the right-hand side of that. But mitochondrial dysfunction, that's oxidative coupling. And we also can get ischemia of those proximal convoluted tubular cells as a result of the previous vasoconstrictive effects. There's some suspicion that you maybe get obstruction of the proximal tubular cell, or just whole nephron essentially, leading as a result of the viscosity of the contrast media and cellular debris as well. And again, hypoxic mechanisms and also I think the intrinsic mechanisms of the contrast media leading to production of reactive oxygen species, all of these causing damage to the nephron. So what's the definition of CMA? Well, back in 2012, PICO defined contrast-induced acute kidney injury as a rise in serum creatinine 0.5 milligram per deciliter, or 25% increase from baseline values assessed 48 hours after a radiological procedure. Just slightly contrast this to the ARIS AKI definition, paraphrased slightly, where we're just defining AKI as a 0.3 milligram per deciliter within a 48-hour period, plus the other parts of that as well. So there's a bit of a difference between the two. However, more recently, instead of referring to contrast-induced acute kidney injury, this is something we'll come on to kind of the rest of the presentation, there's a movement towards this contrast media associated acute kidney injury, because we can't prove this, or can't easily prove this correlation between the contrast media and the increase in creatinine. So what's the situation in human medicine? Well, in absence of comorbidities, the incidence of CMA in human medicine is about 1 to 2%. But this can increase to about 25% in the presence of other comorbidities, which we'll point on a few slides there. It's often self-limiting in probably what we would class as maybe grade 1, grade 2 AKI, but even those changes carry quite a short and long-term clinical consequences. Has a greater risk of death and prolonged hospitalization, and these are even with that just 0.5 milligram per deciliter increase. So ones we would class as almost class as a grade 1 AKI still has an effect on death, mortality, and hospitalization. And it can also be associated with accelerated progression of CKD, although there's that argument of whether it's taking away those compensatory mechanisms as well. And it's associated with long-term adverse events. I think increased risk of cardiovascular problems is one of them as well. But the recent PICO kind of roundtable Ask the Expert summary was, even though this risk exists, the risk appears low with these modern contrast agents, and with normal baseline renal function, so normal estimated GFR. So what are the risk factors? Well, in human medicine, obviously, the biggest one is chronic kidney disease, generally assessed by the estimated GFR equation. And there's kind of a whole range of other cardiovascular ones that you'd expect: hypotension, volume depletion, congestive heart failure, etc. And ACI used as well. I guess angiotensin receptor, but it's not looked at, I don't think. Diabetes mellitus is quite an interesting one on its own. It's not a risk factor for CMA, but it compounds the risk with chronic kidney disease. So if you have chronic kidney disease and diabetes mellitus, which is obviously more common in human medicine than veterinary medicine, there's an increased risk of contrast-mediated acute kidney injury versus just having chronic kidney disease on its own. An intra-arterial administration, so again in human medicine, this coronary angiography studies, these cerebral perfusion studies for cerebrovascular accidents, strokes, myocardial infarction, etc., seems to be associated with a higher incidence of CMA versus intravenous administration. If we look at the veterinary studies, and these are again based on experimental studies, the presence of hyponatremia or the use of furosemide increases the risk of CMA, but there are limitations. Something that's becoming more and more apparent in human medicine is this background incidence of acute kidney injury. And Judy very kindly pointed me towards this Curbsider's Internal Medicine podcast. And on one of the episodes, we had Joel Topf, who is a human nephrologist in the States, and he was discussing this background incidence of acute kidney injury. And I guess rather surprisingly, a lot of the older human studies didn't include an appropriate control group. So they didn't have that group of patients with similar conditions, similar morbidities, comorbidities, etc., and looked at the difference in acute kidney injury between them who didn't receive contrast media and those who did receive contrast media. So it's rather surprising that hasn't really been looked at until recently. And the concern that we're discussing in this podcast is that because of the PICO AKI guidelines, what we're finding is a lot of patients were having contrast procedures up to or above a certain EGFR cutoff. And then very few were thereafter because of this presumed risk or this documented risk, an increased instance of CMA with decreased EGFR. Kind of rather ironically, as a result of this, is that a recent meta-analysis looking at the incidence of CMA, acute kidney injury in stroke patients, found that actually having intra-arterial contrast media was a protective effect. Now, very much most likely it isn't, and what it was that all the patients with normal GFR had the procedures and all those below the GFR cutoff didn't. So it's kind of a false effect from there. Again, the kind of summary from this podcast, and again, speaking to some human nephrologists who I've seen practice with, was if that contrast-based procedure is going to save the patient's life, do it and worry about the kidneys later. Although directly applying that to our veterinary patients is a bit different from there, especially in the UK, limited dialysis, not the option for transplant, and financial changes as well there. So an interesting change in human medicine. So what are the limitations of applying these human studies to veterinary medicine? Well, the majority of the human studies look at intra-arterial administration of contrast media, and very few of them are looking at intravenous, and there is a suspicion due to that increased delivery to the kidneys, less diluted down, that intra-arterial administration of contrast media has a much higher risk than intravenous. And actually, the recent, I think it's a study on meta-analysis, which showed that there was no difference in acute kidney injury, the incidence of it, renal replacement therapy or death between human patients who underwent intravenous contrast media versus an appropriate background population control who didn't have contrast media. So these older studies, they typically use these higher osmolality, these older generation ionic contrast agents, which tend to have or suggest to have a higher intrinsic nephrotoxicity. And again, until very recently, few of them had appropriate control groups, so it was very difficult to compare these older human studies or even some of the newer ones without veterinary patients. And as always, there's that limitation of creatinine as a biomarker, both in terms of its sensitivity, but also its main effect is more of a filtration marker, whereas the pathophysiological mechanism involves both filtration and tubular injury. And something that popped up recently on social media was this study. And this is a reanalysis of the PRESERVE study, which is a human trial. I think it was looking at reducing the incidence of CMA in patients by using, I think it was bicarbonate fluids versus not. And what they did in this study is that they looked at people undergoing coronary angiography, and based on that KDIGO CMA definition, diagnosed them with contrast media acute kidney injury and without. But they also looked at kind of a classic urine biomarkers, NGAL-KIM1, etc., and also the serum biomarkers as well. So in this study, they showed that 8% of patients had contrast media-associated acute kidney injury after their procedure. But very interestingly, when they looked at the urinary biomarkers, there was no difference in urinary renal biomarkers between the two groups. And the only difference they did find was in the serum, that was with KIM1 and IL-18. So although 8% of patients had creatinine to find contrast media associated acute kidney injury, from a renal biomarker point of view, a urinary biomarker point of view, there was actually no difference between the group. There was some murmurings that this may reflect that contrast media is kind of more of a hemodynamic change rather than a truly renal tubular damage change as well, although it's a little bit limited at this stage. So what's the situation in veterinary medicine? Well, there are actually a lot of experimental studies from the 20th century looking at animal models, but again, with them being experimental, we're predominantly looking at intraarterial contrast administration with older generations of contrast agents, those higher osmolality ionic agents. Just kind of quickly just run through a few of them. They do show changes in renal blood flow. They sometimes show increases in glomerular markers, but not on microscopy or electron microscopy. And also changes in renal oxygen perfusion as well. But again, these are mainly intra-arterial. There are two venous studies in veterinary medicine. So this study out of a group in South Korea, what they did is they took healthy dogs and they gave them intravenous iohexol, so I think that's low osmolality contrast media, and as part of a conscious excretory urogram, and they also then converted them to gentamicin AKI models and repeated it then. And they had three groups. They had a group which only received maintenance saline 30 minutes before and 6 hours afterwards. They had a group which they had a group which received nothing, a group which received essentially 6 hours of saline, and a group which received that saline but also dobutamine on top of it. And what they found was that the only difference they found was that 72 hours after contrast administration, the BUN was lower in the group which received fluids versus that group which didn't. But they didn't see it at any other time points. They also didn't see it in the gentamicin AKI models as well. And I guess the other limitation is, well, the two limitations are, one, we don't have the exact BUN values. So was this a clinically significant or just a statistically significant difference? I guess most importantly as well, there was no fluid-only control group. So was this decrease in BUN that we saw predominantly just a result of kind of dilution or hyperfiltration, or was it actually a truly protective effect? So you can't really take much from this study. More recently, in Scandinavia, there was another one looking at the administration of iohexol intravenously in beagles. And they gave two clinical doses of iohexol, 6 to 8 weeks apart, and looked at their scintigraphic assessment of GFR about 72 hours afterwards. And what they found after that second dose of contrast is that there was a 17% decrease in GFR, as well as an increase in the median creatinine. but there was marked intra-dog variation. So if we just look at which were only 5 dogs in that study, but if we just look at the table from that, so the first 2 time points are before and after the first contrast, and then the last 2 time points are 6 to 8 weeks later, again, before and after that administration of contrast media. And after that first one, there's maybe an increase in GFR, if anything, between the groups, although I guess it's hard to tell if that's clinically significant. But yes, after that second dose, there were 3 dogs that had probably I think you quite confidently classed as a decrease, a significant decrease in GFR in 3 of those dogs, but 2 of them there was no change, and then there were no further time points after that. So was it a temporary change? So again, those 2 studies do suggest that there is maybe some influence on it, but I think the methodology and the studied numbers are too low to really comment on it further. So back in 2017, Dr. Fowley from the UK presented an abstract at ASVNU looking at urinary biomarkers with contrast media associated acute kidney injury. And these very kindly lent me some of the slides from this presentation. In that study, they gave intravenous ipamidol for dogs having CT angiography under sedation or general anesthesia. The control group was orthopedic cases which were sedated, but presumably they were having diagnostic or post-op radiographs rather than having other comorbidities as well. And they, using free catch urine and batch sampled it, they looked at the urinary biomarkers before the contrast media, 5 to 12 hours afterwards, and also 12 to 24 hours afterwards, and analysed it with the multiplex kidney toxicity assay, which we normalised to creatinine. So what we found, and this is some very preliminary results, and we are currently writing this up, but we found a decrease in KIM1 over time and a temporary increase in clostridium and osteopontin 6 to 12 hours later that returned to baseline. Now, yes, this does possibly contrast the previous schematic we had with the preserved trial reanalysis, but again, knowing what we know in human medicine with this background incidence of AKI, this is probably an inappropriate control group. More appropriate control group would be matched, Apple or SOFA score, similar comorbidities, similar illnesses, which didn't have angiography, versus this one, which did. No worries, but at the time it's a non-validated assay, so I don't know if that's changed since. And they also didn't provide the non-indexed values, and again, in human medicine, there's this suggestion that in acute kidney injury, there's potentially changes in creatinine excretion, and the raw non-indexed values may have better correlation with long-term survival than the indexed values. So it'd be useful to know the actual individual values rather than the index changes. Again, there's a lack of power calculation at this stage as well. And then recently, Stanton at the Virids Online Congress presented a case of suspected CMA. Now, this case was a dog which was undergoing minimally invasive aortic valve replacement for aortic insufficiency as a result of Bartonella endocarditis, which also had congestive heart failure. The procedure involved rapid tachypacing of the heart, so it was stability, and also involved temporary occlusion of the left ventricular outflow tract due to balloon expansion of the stent. And what we saw kind of post-procedure is quite a marked increase in creatinine, which they designated as contrast media associated acute kidney injury, and I very much appreciate that we're a lot better than me at this. But there are a large number of risk factors in this that could also contributed to this increase in creatinine. We've got pre-existing congestive heart failure, which we know from kind of cardiorenal, venous congestion has a possible influence. Pre-existing renal disease, so quite a marked creatinine at the baseline. Concurrent diuretic use, Bartonella infection, anesthesia, tachypacing, temporary complete reduction of the cardiac output, as well as IV and aortic administration of contrast. So yes, although we do see quite a marked increase after the procedure, I don't think we can fully say that this is solely the result of the contrast media, although it could be. So really, what is the causality from there? So coming on to the paper, which is sent out, and this is essentially, I guess, the only clinical paper we have at the moment on contrast media associated acute kidney injury, and it's a group out of MSU, and it is, from a reasonable time ago in terms of the collection date. So some of these are using that, some of the definitions are using that contrast-induced nephropathy as defined by PICO. Obviously, since then, there's been this movement towards contrast media associated acute kidney injury because of this lack of causality or non-confirmed causation. So the evidence-based medicine question we can ask from this paper is, what is the incidence of CMA in a population of dogs that received intravenous iodinated contrast agents at the university teaching hospital? So the PICO process for this, and I will go into it a bit more detail over the following slides. So the population was dogs that were admitted to the hospital that had creatinine measured within 1 week prior to and 1 week following intravenous administration of contrast between the dates of 2006 and 2012. The intervention they received was that they had 1 or more doses of iodinated contrast media as part of intravenous angiography imaging studies. And they compared the dogs with contrast-induced nephropathy against dogs that received the contrast media but didn't meet the definition for contrast-induced nephropathy. The primary outcome was the incidence of CMA, and they used the KDIGO definition of that, so that 0.5 milligram per deciliter increase in creatinine. And it was within 1 week of receiving contrast media. Secondary outcomes were looking at risk factors that might have contributed to the development of contrast media associated acute kidney injury. So methodology in a little bit more detail was that this was a retrospective evaluation of medical records which received that contrast media, had creatinine measured 1 week prior to and 1 week following intravenous contrast administration. They defined it based on the KDIGO guidelines as a 0.5 milligram per deciliter increase within 1 week, I think KDIGO 1 was 48 hours, of receiving contrast media. Now, the creatinine assays we used varied, and most likely the pre-measurement was from the referring vet, and perhaps a range of analyzers presumably, which wasn't recorded. And the post-media ones were the in-house ones, so they used Beckman culture, and they also used a blood gas analyzer as well. And they took that highest value 1 week post-contrast media administration as being the value to take. They used different contrast media, so hexol, ISVNU, and trizoate, which is one of the older higher osmolality ones. And some of them didn't know which contrast media were used. And the control group was those dogs that received contrast media but didn't meet the definition. Statistical analysis, so it was a case control comparison between dogs that received contrast media and met the criteria for contrast-induced nephropathy, and those that had contrast media but didn't meet the definition of contrast-induced nephropathy. They used descriptive group statistics, including median and range. Now, they used range appropriately, given the small number of samples, but obviously this does have limitations in interpreting the variance and spread of the data when you've got such high ranges. They used non-parametric tests, again, appropriately, but kind of from that disheartening reason of due to having small numbers in the contrast-induced nephropathy group. So yes, appropriate, but for fortunate reasons. And they used Mann-Whitney-U and Fisher's exact as appropriate to compare the characteristics between the groups. They didn't do binomial logistic regression, which, based on this study methodology, would have been preferred for looking at risk factors, but wasn't done. There was no sample size or power calculation. However, given that a lot of what they were comparing was kind of as per protocol, so by definition, based on the creatinine definition, it's a little bit limited of how important that is in some parts of this study. So the results, in that time period, 1,217 dogs received intravenous contrast administration, of which 86 dogs, so 7% of them, had creatinine measured before and after the angiography procedure. Now, 6 dogs had multiple administrations, which we say makes around 92 events available for analysis. But if we look back to that Active Scandinavia Beagle study, whether it is appropriate to include those in that whole population is possibly a little bit dubious. There may be a cumulative effect. Of those 92 events, 7 dogs met the criteria for contrast-induced nephropathy, as well as 7.6%. When we looked at the post-contrast-mediated AKI creatinine between the two groups, found that in that contrast-induced nephropathy group, the median was 1.7 deciliters, so not too bad, I guess. And in that non-contrast-induced nephropathy group, about 0.8 as well. Now, I'm going to go into this table in a little bit more detail on the next slide, but just to kind of highlight the things that we looked for with the creatinine before, the BUN before, creatinine BUN after, and also that delta creatinine BUN as well. And median values, so the number given with the range in the brackets, which often in a lot of places is quite wide, but because we don't have an idea of the spread of the data, it's a little bit hard to comment on how significant some of those changes are. So to break it down a little bit, I put kind of the in British currency at the top and US currency at the bottom. When you look at the baseline creatinine between the groups, there is no difference between those, and it's non-statistically significant difference. However, one of the interesting parts is in the dogs that developed contrast-induced nephropathy, there was no difference, so none of them were azootemic prior to receiving contrast media, whereas actually in the non-contrast-induced nephropathy group, at least one of them was really quite azootemic before receiving contrast media as well. Just for interest, the change in the delta creatinine in the non-contrast-induced group was anywhere between -7.7 to -0.4. So I guess some of those right at the other end were possibly leptospirosis dogs or urinary tract obstruction. And of those dogs, of those 7 dogs that developed contrast-induced nephropathy, only 2 of them were classed as azotemic after, so their increase in creatinine was classed as azotemic. We don't give a reference interval, or whether they used machine-specific reference intervals to comment on that. They only had follow-up in 3 out of 7 of those dogs. One of them was uric, and unfortunately passed away. One of them resolved, so the creatinine went up and then went back to normal. And one remained increased, but it was within the reference interval. So grade 1 AKI, potentially later on going on to stage 1 CKD, wasn't followed up long. And when we looked at risk factors to differentiate between the groups, we didn't find any baseline characteristics that put you in the contrast-induced nephropathy group or non-induced contrast nephropathy group. Or actually, if you look at the numerical value of the amount of contrast administered, it's almost double that in the contrast-induced nephropathy group, so possibly a type 2 error. So I will go into the kind of that contrast-induced nephropathy group in a little bit more detail on the next slide, but just to lead in with the limitations of the study, which there are quite a few. So obviously, quite low case numbers, so it's quite hard to draw conclusions from 7 cases with one which would be classed as an outlier. And being a retrospective analysis, there's obviously this selection bias for dogs that deemed necessary to have that creatinine measured. So obviously, if you had a dog who did the CT angiography or whatever, and the next day it's wagging its tail and eating, and you're probably not going to repeat that creatinine. But if a dog's recumbent and completely unwell, you're going to select for those cases a bit more. And I guess the biggest limitation for me for this study is the control group. And this is going back to what we've seen from those human studies, is there is this, human medicine, at least in hospitalized people, this background instance of AKI of about 35%. And this study doesn't give you the opportunity to look at this. What the study is designed for is a risk factor analysis. So all of the dogs in both cases and control developed contrast media, but the difference between the two groups is whether they develop CMA after procedure. And that's looking for risk factors. What would be more appropriate would be, again, having your dogs that developed, your dogs in the hospital, your control group being dogs with similar severity, conditions, etc., Apple score, Apple fast, SOFA, etc., and comparing that to the group which received contrast media and having a look at that difference in proportion of dogs that developed AKI between the two groups, and I guess risk factors as well for those. There's the limitations of the assay, so obviously they're compared between separate assays. Now, yes, the Veterinary Biological Variation website says that there's only up to 10% variation between creatinine assays, but those are mainly looking at laboratory assays, not your benchtop analyzer or your point of care analyzer, which I guess from my own experience, there can be quite marked differences with as well. So can we say, if they measured it on, an iStat or an EPOC at the referring vet, and then measured it on that Beckman Coulter after the procedure, is that difference truly a change in creatinine or a change in GFR, which I guess we're probably seeing in the patient, or is it just due to the CBA between the machines with variation in assays? And again, the biomarker bias using creatinine, which is, I guess, erring more towards that GFR biomarker, when actually pathophysiology is affecting both filtration and tubular markers. Going back to that reanalysis of the preserved study, actually, is there any other evidence of kidney disease going on rather than just proxying GFR with creatinine? Again, the clinical significance of using a set biomarker. So again, at the end, please tell me if I'm wrong on this, but I'm still in that learning phase. Add to it as you want. If you've got a dog, we know that this relationship between creatinine is inverse exponential to GFR. So you could have that grade 1 AKI dog, and I'm going to have to use British currency here, where creatinine goes from 44 to 88. And you could argue, although I know it doesn't fully work like this, the functional decrease on renal mass or renal function is significantly greater for that dog compared to a grade 5 acute kidney injury dog whose creatinine's gone from 1,000 to 1,044, and probably one of its 4 remaining nephrons is having a bit of an off day. So can we really say that using that same cutoff for AKI or CMA between those different populations is really reflecting the same level of disease, given that it's not a linear correlation between the two? You could argue conversely that, for that grade 5 AKI dog, actually any change is possibly going to be clinically significant for that dog, whereas that grade 1 dog, can they contribute, can they resolve from that? Can they hypertrophy and compensate in response to that change? So should we be using a set marker when the disease is probably not linear across the levels? And then looking at more of that contrast-induced nephropathy group, it's that large number of possible confounders. So looking at the diseases, there's one that had IMHA, 2 with neoplasia, and 1 with hyperparathyroidism, and 3 of them had intrahepatic portosystemic shunts, where you could maybe think, well, actually, is this a population that is increased risk? But obviously, those are going to be the ones undergoing CT angiography, so it has to be taken with a pinch of salt. And there's a lot of potential nephrotoxic agent use, so hetastarch, aspirin, niacin, and debatably furosemide. And then I guess a reverse nephrotoxic agent such as dobutamine could mask some of the changes as well. And a lot of comorbidities. IMHA, 2 of them had thromboembolic events, pulmonary edema, neoplasia. I guess most importantly, 1 had ascites, so that intra-abdominal hypertension, its effect on renal blood flow, and portal hypertension as well. We know in people that the kidneys are very sensitive to that venous congestion. Is that the thing that's caused the change rather than the contrast media as well? And then, the limitations as we come to without an idea of the variance between the two, without graphical representation. So I guess the take-home message from this study is, knowing what we know from the background instance of AKI in human medicine, the methodology of the study doesn't allow us to answer that evidence-based medicine question, doesn't allow us to say what is the instance in this population. Although 7 out of 92 dogs, 7.6% met that criteria for CMA or contrast-induced nephropathy, we can't fully say that change is solely due to the contrast media. I think a more appropriate conclusion would be at least 7.6% of dogs that received contrast media developed an acute kidney injury in the week following administration. So, if we use that virus AKI definition, it's likely that the instance may be a bit higher, given a lower cutoff. And from all of this as well, yes, maybe we did see 7.6% of dogs having an acute kidney injury or as a result of contrast media. But what's the long-term outcome? What's the long-term impact on that? What does that mean for that dog or for us as well? It kind of leads me on to this final soapbox moment as well, is that whenever we have anything in veterinary medicine, medicine at all, be it hemorrhage, MHA, contrast media associated acute kidney injury, on that left side, we have the biomarkers, creatinine, KIM1, urinary NGAL, etc. And they're relatively specific to that disease process, to the kidneys. Relatively easy to assess, but accurate, and it's probably a lot easier to do. But then at the other end of the scale, we've got the things that probably matter more clinically, the ones which aren't proxy biomarkers, the ones that matter to us as clinicians, to the owners, to the dogs, etc. What happens to them long term? Does that massive increase in creatinine mean anything, or they go on living a happy life? Or does a very small increase in urinary ALP actually mean 90% of them die at 3 months or something? And that's a more clinical relevant part, but it comes at the cost of a lot of noise. If you told an owner your dog developed an acute kidney injury following its surgery, are they going to wrap it in cotton wool? Are they going to fill it with omega-3s? Are they going to avoid non-steroidals? Or does it have other things going on? Is it a cavity with mitral valve disease? Is it one of those other changes as well? And I think, yes, we focus a lot on this left side of the biomarkers, etc., but we sometimes negate to look at this other side. However, I'm completely aware that that is a massive limitation in veterinary medicine due to finances, the influence of euthanasia, the research funding we have ability as well. So, any comments or questions? That's my presentation. I hope it's been interesting at the very least. But yeah, if anyone could add to it, from there, that'd be really good.
Thanks a lot, Harry. That was really great. Really excellent review. I guess one question I have to everybody is, are there cases that people have seen that they were pretty convinced that this was the case, and that they had a patient who had contrast-induced nephropathy? I think Harry's point is really important, that many times these patients are ill. They have so many factors that are there. If you think about all the maybe more stable patients that are receiving contrast, like for nasal discharge or something like that aren't hospitalized, personally, I can't recall one of those patients developing a significant AKI if they weren't already hypotensive or having other risk factors. But I'd love to hear if other people were having experiences and seeing these cases in the wild too, because Harry and I have kind of talked about this in the background, about just wondering how often this occurs and how confidently can we attribute it to contrast versus maybe contrast and the comorbidities that are there. And Shelley had said in all of her years, and Shelley, I'll point out that you have very few years. You are very young in your career, but only had one patient that recovered quickly within 24 hours with treatment. So anybody else have experience with seeing these cases?
We've seen a few of Davis, but I think they're very rare. I think when you look at the human literature, I mean, sometimes they can nail this down a little better because They're looking at a specific disease. You're going in because you have a myocardial infarct, or and the incidence of AKI in patients undergoing cardiac surgery is very high, but they're using gobs and gobs of contrast. I think much more contrast than we ever use in our patients. And in fact, one of the strategies now is you get a cardiologist in there delivering lots of contrast, getting much more contrast than the patient probably should have received, and they already have many of these comorbidities. The strategy is to absorb out that contrast with some kind of a sorbent so that you can deliver more to get the study finished. But I think one of the differences between veterinary medicine and human medicine is the magnitude of these contrast agents that they use compared to the quantity that we use in our patients as a possible reason why there's a difference in prevalence.
I would agree, and I think we've had discussions with some of our surgeons and our anesthesiologists about what precautions should we take to try to help prevent that. Is it reasonable to take precautions? And that's a big, there's lots of research that's been done in people looking at protective strategies, anything from saline loading to N-acetylcysteine to literally just drinking a couple glasses of water before your contrast study. And the thing that I've had to remind the other clinicians when I'm talking to them is that you can't just pull any human paper, because as Larry pointed out, and Harry as well too, most of the human literature is in regards to intraarterial injections when people are getting it for coronary angiography. And I don't think that is, it's certainly a higher risk than when you give it intravenously. And we might have that one case report when they were doing the aortic repair, but okay, that's an intraarterial injection. But otherwise, except for the minimally invasive IR groups, we're probably just not giving it that same way. So I think it's really hard to extrapolate the risks that are seen in people and apply them to our patients. But I'm also curious to know if are people taking strategies to try to help prevent this in patients, period, or maybe in patients that have pre-existing kidney disease. I'll say that if we're doing a CT on a patient who's azotemic, we'll probably put them on fluids the morning they come in before they get their CT started, but that's probably all that we might do. And I'm curious to hear what other strategies might be employed.
I think for us, it's varied quite a lot between clinician and where they've trained. So it's anywhere from where I train doing 2 hours to other areas where people are doing 24 hours of fluids, which is obviously quite a marked difference as well. But yeah.
Certainly wouldn't argue that an hour of IV fluids prior to the CT is probably going to be a big game changer.
Yeah.
But surprisingly, in people, like 2 glasses of water sometimes can have a protective effect in a small study. So maybe it does. Who knows? But personally, I haven't seen it be so much of an entity that I tend to put a lot of effort in trying to prevent it. Because I don't think we necessarily have to it in my clinical experience. But I think what's done in people seems to be very similar to what in veterinary medicine, that there's really no standard agreed upon techniques for preventing it or for monitoring it, and they're kind of all over the place in the same way that we are.
Yeah.
I think that's an excellent point, Harry, certainly. Any other questions or comments at all?
I have a question, maybe a little bit off topic, but I was wondering if anyone's had any clinical experience with this Milliplex canine toxicity assay that was mentioned in one of the papers.
Yeah, I think it's one of those bead microarrays. I can't say that I've used it. I know the company Milliplex makes a bunch of these different panels for both human, it's not even really for veterinary. I mean, there's just a bunch of species specific. They have them for mice and rats and things like that. And I think Harry mentioned that I don't believe I haven't seen any validation data on it. I don't know if there's internal validation data that the company has, but I haven't seen that they're actually validated for use in clinical patients. But I can't say I've done a recent review of that. But I don't know if anybody else has them in their hospital or used them.
When I spoke to Dr. Fowley about this about a month ago, he kind of said it wasn't a validated assay, but I'm not sure if he's seen anything since similar to what you're saying there.
The technology is pretty cool because they can run a number of different tests with a pretty low volume, and they can be done pretty rapidly, and you can do a number of patients at the same time on like one of these plates. So it's certainly a high output type test, which when I looked into it, because we had the machine when I was at Penn, but it also meant that if you wanted to do it on an individual patient, it was really expensive because you had to essentially use up the plate. So it was really only something that could be done at that time on banked samples that once you had enough that you could run a plate, you could do, rather than something that was reasonable for on an as patient basis. But I haven't really seen a lot of people who've published anything about it. So I'm curious to see, probably more so the academic institutions, if anybody else has one of those Milliplex machines around that people are starting to play with.
Thank you.
You guys have one at Davis?
No, I don't think so.
Right. Any other questions or comments at all at this point? All right. Well, I'll go ahead and I'll stop the recording.